Hi, good morning to all. So, today we will be taking a new topic from recent advances in hematology, and that is minimal residual disease detection in acute leukemia. It is a very important topic in recent advances, and we will be discussing it under the following headings, that is introduction, then rationale for testing, then clinical importance of MRD detection, sensitive MRD detection techniques, flow cytometry, and real-time quantitative PCR. So what is MRD or minimal residual disease? It refers to the persistence of resistant malignant cells in the bone marrow or the peripheral blood that are detectable by highly sensitive assays when the patient appears to be in complete remission. Okay, and then it also provides an important information on treatment response, and it has strong correlation with risk of relapse, and early detection and monitoring of minimal residual disease is part of clinical management of acute leukemia. So what are MRD cells? So MRD cells are, see, as the name suggests, minimal residual disease. So even if it is minimum, the residual disease, that is the residual leukemic cells, if it is present, then we have to detect it and you have to quantify it and see like how much of the cells are remaining. That means how much is there to be treated, or is it fully recovered, or is there a chance of relapse. To know that, we do this MRD detection techniques. So MRD is the persistence of these resistant malignant cells either in the bone marrow or in the peripheral blood. Okay, they are resistant because we will be already giving the patient chemotherapy, that is induction phase itself. We check after induction phase that whether the malignant cells are disappearing or not. So after induction phase you feel the MRD detection meet is positive, then that means those malignant cells are resistant to the treatment and you might have to go for other protocol or change the treatment or increase the treatment, that is intensify the dose, etc. So it is not only during complete remission that you check for MRD. Ideally, you check these tests to check for the leukemic cells firstly, and it is the same markers that in leukemic cells that you detect that we use for MRD. Okay, so first you will do, usually if you are giving acute leukemia, etc., you will do flow cytometry for the patient. Then those flow cytometry which are doing for early diagnosis, in that itself one or two parameters or markers we will keep it, so that you can use those markers to detect the minimal residual malignant cells when the patient is going into complete remission clinically, or maybe after just the induction phase of the treatment to check whether there is residual disease or not. Okay, some cases if we detect early in early diagnosis itself, you will understand ki, the MRD detection techniques says that there is a chance of relapse for the patient for certain fusion transcripts and gene mutations, etc. So in those cases also MRD detection at early point of the disease itself also tells about how the treatment has to be gone, it should be intensified or not. Okay, so you can correlate it with the relapse, how much treatment you need, etc. And early detection monitoring of the MRD or minimal residual cell disease part of it is part of clinical management of acute leukemia. Okay, so nowadays in every acute leukemia cases we will go for MRD to see whether there is remission and whether there is a chance of relapse. So nextly we come into rationale for testing. Okay, why do we do MRD detection? See, there is resemblance of the leukemic cells to the normal hematopoietic precursors. So you know if it is by the blasts and the percentage that we identify whether the patient is having leukemia or not. But then they resemble the normal immature cells also. But ideally, if you tell, sometimes it is really difficult to differentiate in the blast scheme which is normal blasts and which is leukemic blasts, etc. So it is difficult to differentiate by the morphological features, at times that time MRD detection is very important, or it is very significant. And patient with less than 5% blast is considered remission, but they may harbor 10 raised to 10 leukemic cells and may remain undertreated. Okay, so when you're giving treatment, the blast count decreases and decreases. But when it becomes less than 5%, that is the normal percentage of immature cells which are getting usually in the bone marrow. So we think it is fine. But then actually it is not. Maybe the 5% blasts which are present may be not the normal immature cells, and there may be leukemic cells in that. So if there is leukemic cells, then they should be treated, right? You will just stop the treatment because the percentage has come to the normal range. It is not the scenario as such. So that is why you need MRD detection to see whether the blasts are not leukemic cells and they are normal cells or not. And even if in this 5%, 1% is also leukemic cells, then you will have to treat it accordingly. These smaller number of leukemic cells can be missed by lesser sensitive techniques like conventional cytogenetics and FISH, that is fluorescence in situ hybridization. So these are lesser sensitive techniques which we use to diagnose the leukemia as such, but they are not very quantification for used for very quantification purposes and for MRD. So for MRD detection, you need higher sensitive techniques because see, to diagnose leukemia, you will be already having so many cells in the patient. So it is easier. So lesser sensitive technique is also fine, but for detecting MRD, even after treatment means the cell count may be very less. So the test should be very sensitive. So for MRD detection, you use higher sensitive techniques. Then there is resemblance of the leukemic cells with normal hematopoietic cells, that example hematogones. Okay, so hematogones are lymphocytes that are regenerating, and it can be also seen in children as well. Okay, so why it is seen in children, that you people go and see. And so hematogones, that is normal hematopoietic cells, also they resemble leukemic cells, because you know in leukemia also what is present is blasts and the lymphocytes, myeloid precursors, etc. But you cannot tell that there is mutation in these blasts only by morphology. So it is difficult to estimate the leukemia burden by just looking at the morphology. So that is why you need MRD detection. Okay. So because of the resemblance, there can be over treatment also. So over treatment, why we said here, because see, when you are giving treatment and then you stop it, okay, so suppose it was less than 5% blast and you just thought ki theek hai, now remission, patient is in remission, so you are not doing anything, and then later on the bone marrow is regenerating. Obviously when you stop chemotherapy, the bone marrow is regenerating. So when the bone marrow is regenerating, there will be normal hematopoietic cells or hematogones can be there. So they also look like leukemic cells. But then you maybe, if you're not very experienced, or maybe sometimes you can get confused with the leukemic cells. That means you might be thinking there is relapse happening or remission happening, and then you might treat the patient again. So in this case, the patient might be undertreated. That is when there is less than 5% blast. And when there is so much of normal hematopoietic cells also, sometimes they resemble leukemic cells, and then you overtreat the patient also. So in such scenarios, MRD detection is very important, just for us to confirm also, like whether you to treat the patient or not to treat the patient, and how much residual leukemic cells is there in the patient's bone marrow or peripheral blood. So, what is the clinical importance? Early detection of resistant leukemic cells is associated with high risk of relapse. Okay, so how early you detect there is resistant leukemic cells, that is after therapy you are seeing they are resistant leukemic cells still, then it is associated with high risk of relapse. That means you are seeing there is resistant cells. That means they are not uh, getting effective with the chemotherapy regimen that you're using, or maybe those are really very high grade kind of malignant cells, that is with some kind of certain mutations and fusion transcripts, then there is a high chance of relapse for the patient. Then accurate and precise measurement of MRD help in early prediction of relapse and patient selection for treatment intensification based on poor response to therapy. So this also I said ki accurate and precise measurement of MRD help in early prediction of relapse. Okay. So I said when there is blast is less percentage or when there is so many cells which looks normal as well as leukemic, then you need precise measurement of MRD to know whether the patient has to be uh, treated if it is patient is having residual leukemic cells, and there may be a high chance of relapse if we do not intensify the treatment, that is increase the dose of the chemotherapy or change to a higher medication or second line or third line kind of treatment. So, and conversely, what is happening is that you should identify good responders also who are candidates for treatment de-intensification. Okay. So, in the first case, there is residual leukemic cells, and it is important that you should identify them as early as possible that they are treatment resistant, and then you should intensify the treatment, because if you delay it, the poor response, it can be bad for the patient. So in second case, what is that if the patient is responding really well to the treatment, in those type candidates, you can de-intensify the treatment. You can just decrease the dose or taper it so that you can avoid the toxic effect or side effects of the unnecessary chemotherapy. Now it is MRD detection is also helpful for predicting optimal timing for the hematopoietic stem cell transplantation also. In some patients for some diseases, especially in some kinds of leukemia, if there is no other treatment which is working out for the patient, then maybe you will have to go for hematopoietic stem cell transplantation. In that cases, you have to check whether when all we give first chemotherapy to decrease the bone marrow cells to that level so that the patient can accept the hematopoietic stem cell transplantation. So that also you do by MRD detection, and then you give the hematopoietic stem cell transplantation. Okay, so that it is accepted also. Then it is also useful in better understanding of the mechanism of the drug resistance. That means which type of if the patient is resistant to certain drugs, so when you are doing MRD detection, you can see which clone of cells are responding to what type of drugs. Okay, so we are giving this treatment and it is not working, and if next time we are giving this treatment and it is working and the MRD cells are reducing, then you can understand the better mechanism ki where the drug resistance is happening. Now, what is the basic principle of MRD assays? The basic principle is that the molecular and cellular changes induced by the leukemogenic process used to distinguish leukemic cells from the normal. Okay, so these leukemogenic processes, that is genetic mutations, induce molecular as well as cellular changes. Okay, so the molecular changes is that is fusion transcripts or over or inversion, deletion, etc. That mutations that are happening due to leukemogenic process means because the cancer is happening to the cells, there will be molecular changes. And then cellular changes is that overexpression, underexpression, or aberrant expression of the immunohistochemical, immunophenotypic markers that are happening. So these changes which differentiate these leukemic cells from the normal, means normal cells wouldn't have genetic mutations and aberrant expression of the markers, etc. So but these changes that are there or differences that are there between the leukemic cells and the normal cells, that is the entity which we are using as the principle for MRD detection. So what is optimal MRD technique? Optimal means ideal MRD technique. It should be patient specific or it should be leukemia specific. Okay, ideally it should be patient specific. That means for a patient you should be the markers or certain things, markers or the fusion transcripts or molecular mutations and all we are detecting should be specific for the patient. Okay, or if it is not becoming at least patient specific, it should be at least leukemia specific. Okay, so that means AML or AML M1 M2 M3 or AML NPM1 mutation, AML with PML RARA mutation. So these are very leukemia specific. That is, that type of leukemia will have that kind of mutation. So that is specific for the mutation. And it is not like the whole type of AML will show the same thing, or the whole ALL will show the same thing. Okay, so it is not very leukemia specific then it should be having satisfactory sensitivity, that is minimum 10 raised to minus 4. That means 1 in 10,000 cells, means one cell of leukemia if you detect, that means one leukemic cell is there per normal hematogenic hematopoietic cells. Okay, one leukemia cell per 10,000 hematopoietic normal cells. Okay, so that is a satisfactory sensitivity. Then it should be applicable. Applicable means for majority of the patients the test should be usable, and feasible means how much time consuming it is and how much labor expertise is required. It should be feasible. Reproducibility can be intra laboratory or inter laboratory reproducibility, that is once you do the test and you're repeating it the same in the same lab itself, you should get similar test results, and if you're doing it from the other laboratory also, you should have similar test results. That is reproducibility. Then stable target during the disease course, that is once you find the patient the leukemia is having certain markers positive, then during the course the target, that is the fusion transcript or the markers that you're detecting, it should be stable. That means once you're detecting now, then if you're detecting after some period of time, it shouldn't change. Then your MRD technique will be difficult, because then you cannot detect, then you cannot be sure that we are detecting the same type of cells if you are showing if they are showing another target. So nextly we discuss about sensitive MRD detection techniques. So there are three types of techniques we will be using, that is flow cytometry, that also multi-parameter flow cytometry we use for immunophenotyping. Then we use real-time quantitative PCR based on detection of fusion gene transcripts or breakpoints or aberrant or overexpression of genes. Okay, and then we use real time quantitative PCR based on detection of clonal immunoglobulin and T cell receptor gene rearrangements. So flow cytometry is done by protein expression. Fusion genes are detected at mRNA levels in the RQ-PCR technique, and then the immunoglobulin or T cell receptor junctions are detected at the DNA level. Okay, so these techniques, by because of their principles and all, they detect the change, that is mutation or expression of the markers or genes at different level, and whichever level you test, you will get that the there is mutation or there is expression or there is transcript, etc. So how does this go on? Okay, so you either detect it at the DNA level or the RNA level or the protein level. Okay, so what usually happens in our body, the central dogma structure of molecular biology, the DNA first forms RNA by transcription, and then it forms protein by translation. Okay, and then DNA can self replicate also. So either you detect it at the DNA level or the RNA level or the protein level. Whatever gene mutation has happened, it will express at DNA level or maybe in the mRNA level or in the protein level. You can take any level to detect. So these techniques take the detection at certain levels. Okay. The flow cytometry happens at the protein expression level, and then fusion transcripts are detected at mRNA level in RQ-PCR, and then immunoglobulin and T cell receptor rearrangements are detected at the DNA level. So firstly, we go into quantification with multi-parameter flow cytometry immunophenotyping. So flow cytometry we use with multi-parameter, means detection of different markers at the same time. Okay, so leukemic cells show abnormal patterns of expression of immunophenotyping. Okay, so there is CD markers, CD marker for T cells are 3, 5, 4, 8, etc. And for B cells, it is usually 19, 20, 21, etc. So like that, there are CD markers for mature cells and for blasts like TDT, 34, etc. So leukemic cells show aberrant expression or abnormal pattern of expression, okay? And then multi-parameter flow cytometry detect this leukemia associated aberrant immunophenotype, or we call it LAIP. So they can be of different types. Either they can be cross lineage expression, that is CD7 in myeloid leukemic cells. Okay, usually CD7 is a lymphoid marker, that is T lymphocyte marker, and if it is seen in AML, it is a cross lineage expression by which you can see if there is leukemia cells that are expressing CD7. Normal myeloblasts will obviously not show that, so you can identify that these are the leukemic cells. Maturational asynchrony means there are certain cells which should be seen in the precursor cells. There are certain markers which are to be seen in the mature cells. So if there is simultaneous expression of both the mature as well as the precursor cell markers, then you can know it can be leukemia. So example is CD21, which is a mature marker, mature B cell marker, which is seen in CD34 positive precursor B cell lymphoblasts. If in that you see CD21, which is a mature marker, that is also a sign of leukemia. So that we can detect in leukemic cells and identify that there is residual disease or not. Then there is absence of antigen at times, and there can also be underexpression or overexpression. Okay, so there are certain markers when you study in the IHC, you know ki certain markers may be showing only faint positivity, some show dot positivity, some show strong positivity like HER2 new expression, etc. So what are these CD markers also show the expressions. Okay, they are variable, but they have a certain point of expression. So if that point of expression, there is so much of expression other than the normal pattern, then you should think about leukemia. If there is under expression also compared to the normal pattern, you should know the normal pattern, then you will know whether it is under expression or over expression, then you should think about leukemia. Okay, so why I am telling it's just MRD may you're not thinking about leukemia, you know it is already diagnosed case of leukemia. So MRD may what is the thing why I'm explaining is like in early diagnosis stage we will use the lesser sensitive test to diagnose, like by flow cytometry only we diagnose it is ALL or AML or etc. But then we use multi-parameter flow cytometry and then we quantify also how much of MRD cells are there. Firstly, we will detect the leukemic cells and you will firstly know ki what all are the markers which are aberrantly expressed or overexpressed or underexpressed in the leukemic cells, and we will keep a documentation of it. Okay, and then you will give post induction therapy to the patient, and then we will again do the MRD detection test. So ideally it is the MRD detection is happening when the patient is had done with the induction therapy and you're thinking the patient should be gone into remission now. Okay, so then you check for MRD, and then you are see already at the early time of diagnosis itself you had detected that these fusion transcript is present or the person is leukemic cell is expressing CD21 or CD7, and then you note it down, and then you will put the same marker. Okay, you're not going to do the full panel test as in detection of leukemia, you will just put the markers which you have to test, and then you will just see in the bone marrow or the peripheral blood sample ki how many cells showed CD7 or how many cells showed CD21 as aberrant expression, and then you will see ki how many leukemic cells are residual. If there are no cells that are expressing, that means the patient must be having complete remission of the leukemia. Okay, so like that unique antigens also can be seen, like in ALL NG2 antigen can be seen, which is usually not at all seen in the normal cell. So what are the findings you will get? In TALL, you will get co-expression. Okay, so 34 and TDT are the cells are expressed usually in premature T cells, and then or premature B cells also. Premature cells you will get 34 TDT, and also lymphoblasts in which if you are getting 3 and 5 also in the T leukemic lymphoblasts, Then you should think that mature markers are also present, that is early and late antigen both are being seen. Okay, so that should be leukemic cells. And in leukemic cells, it is little easier to identify through flow cytometry. Why? Because leukemic T cells are usually present normally in the thymus. Okay, you know कि bone marrow cells, that is B cells and T cells, lymphocytes are produced from the bone marrow and they undergo maturation. T cells undergo maturation in thymus, that is why it is called T cells. And B cells undergo maturation in bone marrow, that is why it is called B cells. So normal T cells that are immature cells are should be ideally present in the thymus and very less in the bone peripheral blood and bone marrow. So to identify leukemic cells, and the principle of identification of MRD is by differentiating it from the normal counterpart. The normal immature T cells are usually not seen in peripheral blood and bone marrow, or it is very less compared to other cells. So it is easier to find leukemic T cells. And then in BALL, what are the types of markers that you identify in leukemic cells? There can be myeloid aberrant expression. So in lymphoblasts, if you are seeing myeloid markers like 33, 13, 15, etc. And mature B cell marker, if you are seeing in the blast cells, that is CD21, under expression of CD45 and 38, and either or over or either under expression of 10, 34 or TDT. Then other additional finding is that Costin and Smith et al. Did a study in which they used three-color combination of markers. That is, they used CD 19, 10 and 34 as a combination of marker to detect MRD at day 19 of induction. Okay, so why they use day 19 is that usually 2 weeks you require to decrease uh, the induction therapy to effectively act on the patient, and then the residual the normal normal hematopoietic cells will be almost nil by the time of 2 weeks. So at the day 19, if you are seeing there is immature cells which are expressing this 19 or 10 or 34, then you should consider they should be more likely it is leukemic cells only, because by the time of chemotherapy the normal cells might be will be completely disappeared. Okay, so in that also, see, there are so many markers. I am telling 3, 5, 34 TDT. Here also 33, 13, 15, 21, 38, 45, 34 TDT. So for each marker you're putting in the flow cytometry, that much expensive the test is going to be. So what pathologists try to do is the combination of markers which is really working for them. They use the minimal number of markers to find out what to detect the ALL, as well as to have the MRD to be quantified and to be followed up. Okay, so the panel that Costin Smith et al. Found, the three-color combination was 19, 10 and 34 as a marker for most of the BALL they have studied. This was very sensitive and specific, or you can say the utility of the combination of marker is very high to detect BALL, and use it for as MRD detection also for the follow-up. Then now we will come into AML. In AML, there can be lymphoid aberrant expression, that is CD2, 7 and 19, which are usually lymphoid markers which can be seen in the myeloblast when there is AML. Co-expression is that antigens of different stages, like example 34 is a marker which is seen in the blast. Okay, and then you will see 15 and 33, 15 which is a marker which is actually seen in the mature cells. Okay, so you can see like the same co-expression of early and late antigens. Overexpression can be seen of 33, 34, 64, 45, etc. And underexpression of HLA-DR also can be seen. Then AML cells spread the dot plot due to immunophenotypic heterogeneity. Okay, so you know that in AML there are different types of cells. There is monocytes, eosinophils, and then myeloid precursors that is myeloblast, etc. So that there is dot plot in the immunophenotypic heterogeneity, because there are different types of myeloblast, maybe little expression of rods, little more expression of rods, and then how much of promyelocytes are there, how much of myeloblasts are there, etc. So because there is different types of myeloid precursors, and their expression of rods and all those characteristics is different, the plot which we get in flow cytometry is very scattered. Okay, it is a dot plot, so that will be making it difficult to detect AML in flow cytometry by the plot. Okay, and then light scattering property of myeloid precursor cells in the AML, that is myeloblast, can sometimes be very similar to the normal counterpart of the cells, that is myeloblast of leukemia, may be sometimes showing similar light scattering property as the myeloblasts of the normal bone marrow of the patient. Okay, so in that time it will be little difficult to differentiate it from the normal counterpart, because that is the technique we use ideally to differentiate the normal and the leukemic cells. So coming to the advantages and limitations, what are the advantage of flow cytometry is that it is widely applicable in 95 more than 95% of ALL and more than 90% of in AML cases you can use flow cytometry. It is relatively cheap, rapid turnaround time is there by 1 to 2 days, and it is very directly quantitative. That is, you how many markers are expressed, and from there you can identify what all are the cells which are expressing, and you can just quantify the cells. Okay, but that we won't do, that machine will do. Okay, so flow cytometry in the machine, you can you can tell the quantity of the leukemic cells that is present, which is residual, and it also analyzes normal hematopoietic component also simultaneously, means you can compare it with the normal cells which is not showing the expression, and we know certain set of markers which are seen normally also. So limitation is that it has limited sensitivity. Okay, so the sensitivity of the test is comparatively lesser. See, these all are high sensitive assays which we are using for MRD, but compared to the other method, that is real quantitative PCR which we use, it has a little less sensitivity. But however, there is newer techniques like, see, I said a three color combination marker. So there is latest of six color combination also. You need very good machines and this thing to identify, because there is six colors are used for different types of fusion transcripts and gene expression, etc. So with that, six markers can be simultaneously assessed. Okay, so those techniques have better sensitivity and specificity. Suppose two three markers we are combining, in like that six markers you are combining, and then you are using, then that leukemic cell which you are identifying, you can be more sure that it is leukemia, because we have used so many markers there. Okay, so that will be done simultaneously in flow cytometry. And then it is suggested to follow up minimum 2 leukemia specific immunophenotypes per patient to decrease false negative test. Okay, some cases sometimes there will be conversion to the normal immunophenotype. So you can see aberrant expression, like I said, in myeloid precursors, if you are seeing lymphoid markers like 19 or 5, 7, etc. That that is the one of the aberrant phenotype we are taking. The other aberrant phenotype can be the underexpression of HLA-DR or overexpression of 34 marker, etc. So that is another immunophenotypic aberrant character of the leukemic cell that we are catching. So you should consider like that minimum two characteristics. Okay, like one or two markers and two three characteristics you have to keep in mind. Why? Because if you are catching only one thing, that is the leukemic cell is showing aberrant expression of CD7, suppose in myeloid precursor, and then you are doing later on after giving therapy, you are seeing, and in those leukemic cells you are seeing there is no CD7 expression, so you consider it might be now okay, remission, completely treated patient it is, but actually it might not be the condition. Okay, maybe the aberrant expression of the leukemia after the treatment, it got converted into normal immunophenotype also. So that will be difficult, but that doesn't mean that only one marker we are using might be converted. But then if you are using two three markers simultaneously, there may be only one marker which might be converted, but the other two markers are still present, that overexpression or underexpression which you may be used. So that is what they are trying to tell, key because of the change in the immunophenotype, while you are detecting in the early time of detection itself, you have to follow up two three parameters or two three immunophenotypic characters you should keep for the documentation, so that later on while detecting MRD after therapy, it will be easier if some conversion happens. Then it is sometimes difficult to differentiate hematogones in young children or regenerating bone marrow, because those hematogones also sometimes can show aberrant phenotype. Okay. And then intra and inter laboratory standardization is required, and then there can be technical complexity, okay, for the flow cytometry. So that much expert technicians you will require to run the machines and do the quality control, etc. You should avoid contamination, means two these samples should not be mixed together by any means while you are taking or etc, because then the characteristic of the other type of clone which will be present of other patient, maybe then we will think and document that thing and keep that as aberrant expression, but maybe actually in our patient sample it might not be there. So contamination should be avoided at all costs. So nextly we come to the real time quantitative PCR based quantification of the leukemia associated fusion genes, which are fusion transcripts you will be detecting, or overexpression of certain kind of genes you are detecting by the PCR. So most frequent fusion transcripts are acute leukemia. In lymphoblastic leukemia, you might be seeing translocation of 119, which is showing E2A PBX1 fusion transcript. And acute myeloid leukemia, you can see PML RARA fusion gene. And sometimes in ALL also, the Philadelphia chromosome showing BCR-ABL fusion gene. Okay. So BCR-ABL transcripts are first choice marker when there is fusion transcript positive ALL. Okay, because this is also helpful in the targeted therapy, that is by imatinib mesylate. So how much MRD is remaining or how much residual leukemic cells, according to that we can titrate the targeted therapy also. Okay, so in BCR-ABL positive cases, obviously you will be using BCR-ABL only for MRD detection and quantification, etc. And then sometimes like fusion gene detection, there can be other genes also that can be overexpressed. The WT1 protein can be overexpressed. Like in AML, 70% cases you will get WT1 overexpression. Sometimes you might get aberrant expression of EVI1. And then somatic mutation of NPM1 also can be detected by RQ-PCR. Okay. And then post induction therapy, after you are giving the induction chemotherapy, high levels of WT1 is persistent in the patient, then it indicates that the patient will obviously relapse within a period of 1 year according to the studies. And then if the patient is showing FLT3 ITD presence in the AML in the early time of diagnosis itself, if this fusion transcript is present, then there is 8.5-fold or times chance of MRD cells will be present. That is, residual leukemic cells will be present after the first course of chemotherapy. That means the patient is having high chance that it won't be going into remission. You will need intense therapy for the patient. Then what are the advantages of this technique? So RQ-PCR, by which we are quantifying the fusion gene transcript. Okay. So in the advantages that it is an easy technique. It is faster by 2 to 3 days. You will get the result, and it is very highly sensitive compared to the flow cytometry, and it is leukemia specific. Okay. Leukemia specific means, the fusion transcript that won't be seen obviously in the normal cells. So it is more specific to the it is more specific test. Then there is strong association between leukemia cells and molecular abnormalities. The same thing, that is normal cells wouldn't show the fusion transcript. Limitation is that the applicability is less. Not all leukemic cells show fusion transcript, which we have identified. Okay, so there may be hundreds of fusion transcripts which we have not identified also, but the identified fusion transcript and the markers we have, that is the transcripts which we can use for this test. So like that, if you are seeing only BAL 40 to 45 percentage leukemia might be showing the transcripts, and TALL may 15 to 35 percentage, and in AML maybe only 20 percentage of AML will show these fusion transcripts which we know about and which prob we can put, not prob but the transcripts which we can be identified. And then cross contamination of the RT-PCR products cause false positive results. Okay, so cross contamination again with other patient sample, you should not mix it, or it should be like very sterilely you are doing all these procedures, because then it might be false positive, other patients sample might be positive, and little bit it got contaminated to our patients this thing, and then we will take it as a parameter for detecting it for MRD for the patient after the induction therapy, so it will give false positive results. So that also should be taken into consideration, that cross contamination shouldn't be there. The number of targets per leukemic cell vary among the patients. Okay, so and among different cells of same patient might be affected by therapy. So we think that one fusion transcript will be seen per cell, but that is not the case. Sometimes there can be more number of transcripts even one cell. Okay, you know that atypical mitosis and all happens. So when there is so much of division of the chromosomes, the transcript is there can be no so many transcripts in one cell itself. And the transcripts also can be converted. Maybe sometimes the transcripts might be shown in some leukemic cells, in some leukemic cells it might be not there also. So because of this difference in the transcript expression, the quantification is also little difficult, because if you see suppose one cell is showing 3 to 4 transcripts, you are thinking that one transcript per leukemic cell, so that the quantification is difficult because it is not precise now. So this is a limitation of flow cytometry. So nextly, to discuss the third technique, you should know that immunoglobulin has heavy chain and light chain. Okay, and in that there is a constant region and variable region. Okay, in the light chain also, this part is constant region and this part is the variable region. And in this full heavy chain, this is the variable region and this is the full constant region. Now why? Because this part is variable is that because that is the antigen. Usually antibody acts in response to the antigen. So this is the usually the part where the antigen comes and binds. So this part keeps on varying, because it should identify different types of antigen. Okay, so these are variable regions. So there are different combinations of VDJ util, that is variable diverse junctional areas. So you can see, while forming those variable regions, there are so many segments that get together to form the protein. So like you see in this picture, this is a constant region and this is the variable region, okay, of the heavy chain and the light chain, as we said. And so in that there are segments like variable segment, diverse segment, and J is the junctional segment between the constant and the variable region. So there are so many type of segments inside the V area only. You can see V1, V2, V3, V4, V5. There are different types of segments. So these segments can be different proteins, suppose, that will express these immunoglobulins. So what happened is that there are different D segments, there are different J segments. So while development of immunoglobulins, that is B cell, when it is developing itself, maybe while dividing the mutation, because of the mutation, there may be different combinations of variable region or diverse region or the junctional region that can cause different types of recombination. Okay, so because of different kinds of recombination, that type of protein or mRNA will be expressed. So because of this variable kind of recombination, that becomes a characteristic for the leukemic cells. Okay, so those clone will show certain kind of V, D and J segment combination. Okay, so that combination of what the segment was, like suppose V1 got clubbed with D3, or V4 got clubbed with D5 and J3. Okay, so that combination of clubbing that that can be a characteristic to the leukemia clone which we are detecting. So that is also one more specific test that you're using in ALL. Okay, so Ig means immunoglobulin is produced from B cells. So for B cells, this can be used as a technique, and in the same way, T cell receptor gene also shows rearrangements that can be detected by PCR. So this is a technique that is immunoglobulin में the VDJ segment का recombination and the T cell receptor gene rearrangements. So these characteristics can be used by detecting and then for monitoring the minimal residual disease. So rearrangements that occur for T and B cell development of these things can be happening by insertion or by deletion. Okay. Clonal rearrangements are clonal specific and they generate patient specific DNA lengths and sequence. Okay. So I said fusion transcripts are detected at the mRNA level, and then immunoglobulin and T cell receptor gene rearrangements are detected at the DNA level. So when these combinations are happening, so according to the length of the gene present, that is the V1 expressing gene may be this much, and then V2 expressing gene may be this much, and then D expression, J expression. So what all components are there? Like V1, V2, V3 is together means this much will be the length. Only V1 is there, this much will be the length. So according to how much the length of the V component, D component, J component, the DNA lengths and sequence also will be that much length. Okay. So according to that, the rearrangements, DNA lengths and sequence will be varying. So that will be also a characteristic point of that leukemia, and that will be patient specific also. Okay, for the same leukemia, if you are looking VDJ recombination of some other patient, it will be different. So this is a test or technique which is patient specific. So even if there is cross contamination by some other cells, patients also, if it is very less, it will be you can detect that the patient DNA lengths and sequence are of certain characteristics. And if you are getting little contamination, you will understand that that is contamination and not the patient ka cells. Okay, because this combination will be seen only in patients, one type of patient, but still cross contamination should be avoided in any case. So this recombination will be seen in leukemic cells only, and it won't be seen in the normal lymphoid population. So what are the advantage of this case is that it is widely applicable in 90 to 95% of the cases of the ALL, that is showing B cell and T cell, etc. So they, because T cells can be recepted by T cell receptor gene and B cells can be detected by the Ig recombination VDJ. So this is applicable for ALL 90 to 95% cases. Limited applicability in AML. It is good reproducibility. Okay, in other two tests there is no good reproducibility. Reproducibility means intra-lab variation and inter-lab variation. Inside the lab itself the variation is very less, and between the labs also test results variation is less. Good sensitivity is there. It is patient specific, as I said. There is rapid, it is rapid test during follow-up. Otherwise it is little time consuming. It is expensive and laborious also, that is labor intensive. But once you have detected the gene rearrangements or and VDJ recombinations and all, then once you have detected, the follow-up is rapid. Okay, then these tests are standardized by certain authorities. So the other tests are not standard only, but they are not really standardized. Methods were not present, but for this test it is present. And then there is presence of multiple limitation में there is presence of multiple clones with rearrangements. Clones can evolve. The minor clone can predominate later. So see, clones can evolve. That is the point. See, I said ki one type of VDJ recombination is seen. And then you see there is not only that leukemia cell that is clonal proliferation, but there can be 2 3 type of clones also in leukemia. Okay, so in that minor clone, major clone and all will be there. So suppose the major clone which we were studying and which were noting for the MRD got evolved and they got converted to the normal one. Okay, or they evolved by chemotherapy or induction, and also they are not at all showing now that VDJ recombination, etc. So that time what we will do is that maybe the minor clone will predominate now because after the therapy. So it is mandatory now that like the fusion transcript or the flow cytometry, minimum two immunoglobulin or T cell rearrangement targets you should be following for MRD detection. Not only one clone you will be catching and setting, you should check for one more or two more clones and keep it ready so that these VDJ recombinations also you will be checking on for MRD detection. That is, if the major is not there, at least the minor VDJ recombination which we had kept for the second most common or third most common you had kept is showing, means there is leukemia cells. Then some rearrangements can be similar in normal lymphocyte. Okay, some normal lymphocytes also may be showing some VDJ recombinations, which you should be knowing the patterns. Okay, so but some normal lymphocytes may also show some of the rearrangements which are actually seen in the leukemia cells, but they will be seen very less quantity. But there is a chance that it can be false positive. So comparing all the MRD techniques, flow cytometry detects by the protein level, PCR or fusion transcript detection is detected at the mRNA level, immunoglobulin or T cell receptor rearrangements are detected at the DNA level. Applicability, flow cytometry is widely applicable in both the types of acute leukemia. Fusion transcripts has comparatively very less applicability, but compared to ALL and AML, it is more applicable in ALL. And the immunoglobulin and T cell receptor rearrangement by PCR is obviously more and very well useful in ALL only. And in AML, it has very less applicability. Sensitivity wise, fusion transcript has very high sensitivity, and immunoglobulin and T cell receptor rearrangement has good sensitivity, and comparatively flow cytometry has little less sensitivity. And then turnaround time is rapid for the first two techniques, and it is time consuming in at the starting for the immunoglobulin and T cell rearrangements. For follow up, it is little rapid. Expense wise, flow cytometry is comparatively cheaper. The flow cytometry and fusion transcripts are leukemia specific. I said cross contamination is not at all allowed, and but in immunoglobulin or T cell receptor rearrangement is patient specific. Technical complexity is there in flow cytometry, so you need, it is labor intensive, so the technician should be really very expert. And then for fusion transcript, it is comparatively easy technique to learn and teach also. Immunoglobulin and T cell receptor also, it is laborious, only you need real very technical knowledge to perform the test. Other features में flow cytometry is directly quantitative. Fusion transcript, it is very useful in differentiating the normal and the leukemic cells. But precise quantification is little difficult because maybe in normal cell only you can see different number of transcripts. And in immunoglobulin T cell rearrangement, there is good reproducibility, that is intra-lab, and inter-lab reproducibility is good, and the methods are standardized. So what is the timing of the MRD detection? The timing of MRD detection is, first you will do early diagnosis. You will diagnose the patient, and that time also you should have run the MRD you are going to do, the MRD test you are going to follow up. That is, you are either doing flow cytometry and identifying the aberrant phenotypes and keeping, or else you are using the fusion transcript probe, and then you will see which all fusion transcripts are positive, and then you will note down. Or you're using the immunoglobulin rearrangement, then you should do that pehle se, and then you should find the VDJ segment which are positive, or the combination which you will be uh, documenting and keeping for further follow-up for detecting the leukemic cells later on after the therapy. So first you did early during the diagnosis stage, you will do an MRD detection, and then after induction therapy, you will run again all the tests to see how much of the residual disease is present. So the presence of residual disease, even if it is 0.01 percentage or higher, this is taken as a cutoff, that is 0.101 percentage or higher. If the patient is having MRD at the end of the in induction phase, it is correlating with poor outcome and there is a high chance of relapse. Even during early diagnosis, if there is 0.01 percentage or higher leukemic cells, it is usually correlating with poorer outcome. But then it is more specific when you're detecting it at the end of the induction phase treatment. So lastly, we tell that whether MRD is detectable in peripheral blood. So I said MRD is usually detectable in bone marrow ideally, but it can be detectable in peripheral blood also. But it is different for different leukemic cells, so that you should know. In BAL cells, ideally, the residual disease cells are higher in bone marrow. And if the cells are present in peripheral blood, that means it is more aggressive and there is high risk chance of recurrence of the disease. And in TALL and AML, almost bone marrow and peripheral blood will show the similar number of quantity of MRD cells only. So in TAL and AML cases, central MRD testing can be performed even with the peripheral blood. So what is the importance is that you don't have to again and again prick the patient or give an invasive bone marrow aspiration again and again for MRD detection. So in such cases, you can just go for the peripheral blood also for the MRD detection. So it was an extensive class. So we come to the end of the recent advances. Hematology part 3 article of MRD in acute leukemia, and I take this opportunity to thank Seema Tyagi and Sanjeev Kumar Gupta to for contributing such a beautiful article in recent advances and enlightening us. So if you like this, please do like, subscribe, and you can comment for the topics which you need me to present for the next time. Thank you.